Thanks for joining us to talk about pediatric asthma care at Helen DeVos Children's Hospital. I wanted to start the discussion by laying out the rationale for why we changed our policy. Primarily, we wanted to standardize asthma care across our system so that when children came to the emergency department, whether they were going home from the emergency department or being admitted, we were all on the same page and working within the same system. We feel that by having a more standardized and aggressive asthma plan, we can decrease the need for admission to the hospital for children from the emergency department, and also decrease our length of stay in the emergency department as well as on our inpatient units. And this would be because our care would be standardized. We're going to be more aggressive with our care, especially up front. And then there's a well-defined weaning policy for children on the inpatient service that James will describe further a little later on. And you might ask why we think we can do all of this with just a policy change, and that's because other well-respected children's hospitals have done similar policies and have published impressive success. Both of us have practiced at those, two of those facilities. I come from Seattle Children's Hospital, where we had a very similar asthma plan, and kids flowed very nicely through that hospital when they came in with asthma. James came from Children's National, where again, a more standardized asthma policy allowed them to provide more effective and efficient care to their kids with asthma. So I want to lay out the big changes right in the beginning, because these are the things that I think your patients are going to be talking to you about. We're going to be increasing the use of continuous albuterol nebulization. In the past, this was saved for children who came in with the most severe symptoms and was really thought of as sort of a way to stave off intubation. Now we understand that continuous albuterol is appropriate and effective for kids with even just moderate symptoms. So you're going to be seeing children who come in with more moderate symptoms being placed on continuous albuterol in the emergency department from the beginning. We've also developed an asthma score, which is an objective standardized scoring tool that will help determine the flow of these kids through the hospital. It's also going to help us communicate to each other in a more standardized way how sick a child is with their asthma symptoms. And then in the emergency department, dexamethasone has replaced prednisolone for the steroid of choice for asthma care. The evidence for the use of dexamethasone in the outpatient world for asthma care is really very good. There are a lot of Cochrane reviews on this topic. The use is basically equally efficacious if you compare it to prednisolone, but dexamethasone has a decreased risk of vomiting. And in our patient population, we have a problem with adherence to the treatment plan. And so when children receive a single dose in the emergency department and require only one more dose at home 24 hours later, we feel our adherence is going to be greatly improved by this process. We also want to acknowledge that not every patient is right for the asthma pathway. So we are really looking for that select group of children that come in with standard asthma problems. We're excluding children under 2 years of age because we don't want children with bronchiolitis to be mistakenly treated as asthmatics. And then children who have acute illnesses other than asthma, or kids with pneumonia and croup. Children with primary lung diseases such as cystic fibrosis will not be right for the pathway. Those with airway issues are again not right for this pathway. And then medically complex or immunocompromised children will be excluded. And then we have that group of children that require immediate critical care interventions and admission to the critical care unit. And those children really need specialized physician-run care from the get-go. And so those children will also be excluded from the pathway. So when children come to the emergency department, they will be triaged into either high or low acuity areas based on their asthma score. The score is calculated from 0 to 12 based on their respiratory rate, their retractions, their degree of dyspnea, and their breath sounds. Those who have a high score of above 5 will receive a 15 milligram continuous nebulization of albuterol with 1 milligram of Atrovent over the first hour of their ED visit. Those who have a low score will receive 8 puffs of an albuterol MDI with a spacer and a mask, and then they'll be observed for about an hour after that prior to discharge, as long as they have improved. We are switching to an increased use of an MDI versus a neb for those kids with a low score. We still have the option to give a 5 milligram neb, which is our standard ED dose, if a child can't tolerate the MDI. But there's really excellent evidence that the use of an MDI with a spacer and a mask, even in a very young child, is equally efficacious to a neb. And especially in our population, we really like to know that that parent is going home with albuterol in their purse that they can give to their child at home. And then all children will receive 0.6 milligrams per kilogram of dexamethasone with a maximum dose of 16 milligrams. They'll get their first dose in the first hour of care in the emergency department, and then they will go home with one subsequent dose to be taken 24 hours after they're discharged from the hospital. So the dose that they receive in the emergency department will be the IV formulation given orally, and that is a well-established practice, been going on for a lot of years. The dose that they will take for home is going to be dispensed as 4 milligram tabs. Older children can just swallow those. Younger children can have those crushed into anything that tastes good, syrup, honey, pudding, what have you. We chose the tabs because the elixir has a high alcohol content, tastes really bad, and has a really high number of milliliters required for most kids. So this is our asthma severity scoring tool. You can see it's a very simple tool. The respiratory rate is broken down by how old the child is, and then just typical clinical indicators of severity for difficulty breathing are included. The people who do this score are typically our respiratory therapists, or in the emergency department also our nurses. And then this is the first 2 hours of asthma care in the emergency department laid out in the pathway. We will care for kids with asthma for up to 3 hours prior to making a disposition decision in the emergency department. In phase 1A, that is the first hour, you can see that we break kids into 2 groups, those who are low acuity or high acuity. In the second hour, kids will be broken into 3 groups, either those children whose asthma symptoms are much improved and they are ready for discharge home, those children who still are experiencing significant asthma symptoms and need further care but are improving, or those children who really remain quite sick and it's clear they need to be admitted to the hospital at that time. So the disposition from the ED will be based on repeat asthma scoring, and we will start to make those disposition decisions after the first hour of care, which is much sooner than we used to do it. Those who respond well to therapy will either be discharged home or can continue care for up to 3 hours in the emergency department. Those who are not responding well will be admitted either to the intensive care unit or the inpatient unit based on their asthma score, their overall response to therapy in the emergency department, and any signs of impending respiratory failure. So I'm going to turn it over to James Van Beynen to talk to you about the inpatient care and discharge from the hospital.
Okay. And I'm going to first kind of lay out what I noticed when I first came back to Helen DeVos Children's Hospital and the treatment of asthmatic patients compared to when I was over at Children's National Medical Center over in Washington, D.C. The first thing we did before we even started this new guideline or policy is we wanted to reduce the time that the patient was in the ED and also reduce the time from which I accepted the patient and the patient was transferred to the acute care floor. So what we're trying to describe here is a continuum of care. We don't want the patient's treatment of asthma to be impeded by where they are within the hospital. So within the emergency department, it was nice that within each hour, the patient is always getting a treatment, and then you know what's going to happen over the entire next hour. And when we get the patient accepted to the floor, we try to get that patient accepted within that 1 hour time frame. So there's going to be no delay in the patient receiving albuterol once they do reach the acute care floor. Prior to this, what would happen is the patient would receive albuterol within the emergency department. They would be decided to be admitted to the acute care floor, and we would get the phone call from the ED attending and it would say, well, let's wait for 2 hours because standard on the floors right now is the most albuterol we can give is 5 milligrams every 2 hours. So that would be the patient just sitting in the emergency department for 2 hours, occupying the bed, and just waiting to see where their appropriate therapy was and determine if they would either be admitted to the ICU if they required further care, or if they'd be accepted to the floor. So right now we're pulling these kids out of the emergency department much sooner during their asthma treatments, and we're getting them up to the floor much sooner as well. And then what we want to do with our asthma score is create a better culture of communication, and provide standardized care. The new terminology will be, if Erica calls me up, she'll just say, yeah, I have an asthmatic that presented to the emergency department with an asthma score of 9. They received their albuterol therapy. I'll already know that it's 15 milligrams continuous. The patient now, after 1 hour of therapy, is a score of 6, and they're ready for the floors. So she doesn't have to go into the clinical symptoms that this child is displaying. Just by providing me with the asthma score, I have a clinical picture in my head of how distressed this child was, and I have a good indication of how much this child improved with the treatment modalities that were given within the emergency department. So it's a much more efficient, much more clear way of communicating. And then the other part is, once the child is on the floor, we want to provide appropriate therapy all the time. There was frustration with our respiratory therapists because depending on the attending physician, they would not know what dose of albuterol would be given, what frequency of albuterol would be given. Do we give it now? Do we give it later? So the orders were all over the place. Sometimes we had a Q2 hour dosing, a Q3 hour dosing, a Q4 hour dosing. And when the attending physician would assess the patient, we would just say, okay, I think it's appropriate to give this patient 5 milligrams every 2 hours. And I'll get back to the patient sometime this evening to reassess the patient. But now this guideline, it's respiratory driven. They're the ones in there assessing the patient all the time. They're the ones that are providing the asthma scores. They're the ones that are informing the attending physicians when it's appropriate to start either weaning the albuterol, or in rare cases where the child needs more albuterol. And then based upon what they're seeing, the dose can get changed. So this is what has been done on the adult side of the hospital, even at Spectrum here, for some time. But in pediatrics, we got a little bit nervous with these younger kids, worrying that they're going to decompensate, especially over the evening times. So when I first came here, you would see very rarely a change in the dose or a change in the frequency in patients that were receiving albuterol during the evening because we were too scared to change things. Now with the scoring system, the respiratory therapists have the tools to know when to change these things, and with the education provided to the medical staff, we have the comfort where we allow them to change it. And if we're ever uncomfortable, if there's a question of the asthma score, we can go into the room at the same time the respiratory therapist is there and look at the asthma score ourselves and can compare the two. And most of the time, the asthma score will be the same. And the last thing is we've been noticing with this more intense program, a decrease in length of stay. Being more aggressive upfront allowed these kids to get more out of the hospital even sooner. And I think that's mostly with what's being done within the emergency department. This is just a diagram that I wanted to show everyone of the entire guideline. I'm not going to go into details with this. The upper part with the more colors with the 3 stages is what's done in the emergency department. But as you can see, it is a continuum, and everything below that is what's done on the acute care floors. This is available anywhere within the hospital, and everybody is becoming familiar with it. With the Albuterol Wean that we're doing, we kind of put these kids in phases depending on what their asthma score is. A high asthma score means the patient is more sick or ill. We are doing something that's new here. We are doing 10 milligrams of continuous albuterol while on the acute care floors. Prior to this guideline, all continuous albuterol was done in the pediatric ICU. But nationally, a lot of hospitals have transitioned this to, if the patient looks well, this can be done on the floors. Of course, there are criteria that we look at to see if the patient does have to go to the ICU. We only currently do this for 3 hours on the acute care floors. After that, we reassess the patient to see if they have to go to the pediatric ICU. And then as they're done with their 10 milligrams over an hour, the respiratory therapist will go in and reassess them. If they're improved, meaning a score of 5 to 8, then we transition them to the 5 milligrams of albuterol every 2 hours. At this point, we are using the nebulized treatments for that frequency. Once we transition them into phase 4 and phase 5, their scores are 0 to 4, and they're kind of getting better. And at that point, we can either give them the 5 milligrams of albuterol or the 8 puffs via the MDI. And it's kind of nice to do that. Same with the emergency department. We know that they're going to be going home with albuterol in spacer in hand. And it's very reassuring when we know they have that. And this is just a little bit more demonstrating what we do on the acute care floors. And I'm not going to go into any further detail with that because I did go over the weaning of albuterol. And the last thing that we're doing is we did something that the outpatient clinics might see is these families will all be going home with the asthma action plan as before. But as we're trying to integrate more and more things into the electronic medical record, we are having these asthma action plans being printed through our computerized system called Cerner. And it was difficult, but we are able to print these in color, and families will be going home with these new types of asthma action plans. I know they change pretty commonly, but I wanted to let everyone see what the new current asthma action plan will look like.